What's up, everybody? This is Dr. Brad Watts, and you are listening to another episode of Nutrition Hero Podcast. Welcome to the program today, and I'm excited. I got a couple of things I want to share with you, some things that I think are going to make a difference in not just how you view patients, but maybe how you view your own health. So, cool. If you missed it, this last weekend I was out teaching in Arizona, blood chemistry course, and I had fun. It was good information. It was good to see everybody that came out. I appreciate you for supporting that, and I hope you learned a lot. So I'll have updates on when you can participate in another program, kind of like that, coming up. And obviously we're going to be certifying people as well from a blood chemistry perspective, so that'll be fun. Today I want to talk about an aspect of blood chemistry, specifically anemia patterns, because you're going to see them in practice, and it's important to understand when an anemia pattern is something you act upon and when it's something that you just watch, something that you keep track of on an ongoing basis, and what it actually means. So before we get to that, I have a couple of things I want to describe for you here, some information, different articles that I'd like to keep track of in the news media, and specifically as it relates to health. I was looking at one the other day in a magazine specifically, so not necessarily peer-reviewed, right? But looking at a magazine article that was citing some research that talked about plank exercise. So I don't know if you have seen this, but there's these viral videos going around where people are having a plank challenge, and it's something that has become relatively common. But, you know, where you're on all fours, prone, on the floor, core exercise, the plank. One of the things that you're going to find is that plank exercise has been demonstrated to show or have a correlation with your overall health and your vitality. And so what's happening is people are correlating your core strength to your overall form and function. Well, the other day, some guy set a new world record for this, and I just had to mention it because it's so ridiculous. The previous world record for a plank was over 5 hours. Think about that. Like, I'll do a plank, and after a couple of minutes, you start to sweat and shake, and it gets a little irritating. 5.5 hours this gentleman had a world record, for a few years anyway, and so it was just broken the other day, and this is worth noting. Some guy held a plank exercise for over 8 hours. 8 hours, what in the heck? So in that instance, what I wanted to do is just give this gentleman a shout out. What in the heck is going on here? 8.5 hours holding a plank for a world record. How long do you have to practice in order to get your core strength up that high? My goodness. And what is going on with his ability to hold that plank? What's going on with his muscular endurance? What's going on with his ability to form and then process lactic acid through the Cori cycle? It's crazy. So anyway, that was so ridiculous, I just had to throw that out there and talk about that for a moment. Next thing that I want to talk about is a research article from the Cambridge University, So I have a citation here sitting in front of me, and this is interesting. So I'm just going to read the first study here. Almost half of people over 65 in the UK, by the way, are taking at least 5 different drugs a day. Almost half the people over 65 are taking 5 different drugs a day. That's coming out of the Cambridge University Research Department. And this is in the UK, all right? So if the United States is always amplified from what the UK is, just think about this for a second. The figure in the UK has risen from 12% just 20 years ago, 12% of people taking 5 medications or more, all the way up to 50%. That is insane. That is insane. And the amount of people that are taking no medications over the age of 65 has dropped from around 20% in the late 90s to over 7% today. So that means only 7% of the people over the age of 65 in the UK are taking no medications. 7%. So, and again, if we can just correlate this to the United States, what are we going to be seeing in the long run here? This is amazing. Absolutely stunning. 50% of people over the age of 65 taking 5 medications or more. 5. Think about your patient base. Your patient base is going to be the sickest of the sick in the United States, and if it's not yet, it's headed in that direction. 5 medications for 50% of people or more. I would be interested to know, in a functional medicine setting, how many medications are your patients on? What's the average? That's a very, very large number. In fact, let's do this. We're going to do a poll. You can just send the information to brad@biogenetics.com. Your patient base, what's the average number of medications that these people are on? This is wild, by the way. So anyhow, I just had to mention that. That's coming out of Cambridge University. You don't see a lot of studies like that in the United States for whatever reason. But anyway, if you have a link to one, send it to me. I'd be interested to hear about it. So, all right. So today, the rest of the time today, what we're going to be discussing, what we're going to talk about are different anemia patterns. And anemia has always been an interesting thing to me because you know enough about it to be dangerous, but how much do you actually know when we get down to the roots of it? So, an anemia is basically the inability to carry oxygen into the tissue of the bodies. What do you need oxygen for? Well, obviously, we need oxygen in order to produce energy, right? Like you take sugar, turn it into glucose, you take oxygen, you mash the two together, and it gives you ATP, and then you exhale with your mouth here. You're exhaling that CO2, and so somewhere in the middle there is where an anemia pattern is affecting your physiology. So one of the things that I get an opportunity to do, just like recently this weekend, is talk to doctors about anemia patterns and how to analyze them specifically on a blood chemistry. And these anemia patterns are interesting to me because what happens is a doctor always wants to think about it from the perspective of iron. And it may or may not be an iron-based anemia pattern. So I'm going to throw out a couple of things here today that hopefully help you problem solve a little bit differently. So grab a pen, pencil, whatever it is, grab your number 2, and let's go through the process. So in a CBC, typically what we're going to be looking for are high, low, and dysfunction. What I want you to be looking for with an anemia profile is red blood cell, hemoglobin, and hematocrit. If red blood cell, hemoglobin, and hematocrit, if either of these, or any 3 of these, if one of them is elevated or depressed, if all 3 of them are elevated or depressed, we have a suggestion of different types of anemia patterns. If it's decreased, this anemia, all right, this inability to optimally deliver oxygen to cells of the body, has to be identified. It doesn't tell us where the anemia is coming from, what type of anemia pattern it is, but at least it tells you that there's an anemia there. Now, I throw this out because you'll have patients that come to your office and the doctors that they've been seeing will have red blood cell or hemoglobin. Red blood cell will be normal, hemoglobin will be low, and the doctor says, you have an iron-based anemia, and they put them on iron, even though they're never testing the iron itself, right? So I'm pumping the brakes here for you because that's wrong. You can't do that. Can't do that. So if you see that, I want you to make sure that you get a little animated and be able to throw that out there and say, hey, this is crazy. You can't just diagnose iron-based anemia without ever running iron or ferritin. And so in this instance, RBC, hemoglobin, hematocrit just tells you that there's an anemia when it's low. It doesn't tell you what it is or why it's there. What we want to do is look at the next layer here of the CBC. So we're looking at MCV, MCH, and MCHC. MCV, MCH, and MCHC suggest the cause or the type of the anemia pattern. So remember, RBC, hemoglobin, hematocrit tell you that there's one there, but the MCV, MCHC, and MCH tell you essentially the cause, why it's there, right? Why it's there. Now, the secret weapon in a CBC is something that most doctors don't even run, and it's called the RDW, red cell distribution width. Red cell distribution width tells you essentially about the integration of red blood cells. So let's look at it from a perspective of diversity. Is there a large red blood cell next to a small red blood cell, right? Your RDW value is going to be higher. If they're all small, the RDW is going to be on a lower end. So RDW is looking at the diversity between the size of a red blood cell. RDW is going to help us indicate whether or not the anemia is from a nutrient deficiency or not. Maybe it's from an inflammatory issue, etc. So let's go through these 3 layers again. These are the 3 layers of how to analyze an anemia pattern on a CBC. Every single patient blood test that you have, you should be able to do this with. So RBC, hemoglobin, hematocrit. Is there an anemia? It tells you if the anemia is present. MCV, MCH, MCHC are going to suggest the cause or the type of the anemia. And then the RDW is going to tell you if it's from a nutrient deficiency or not. So there's only 3 causes for an anemia pattern, if you remember: production, destruction, or loss. Production anemias happen with nutrient deficiencies, which you would see a high RDW. Lack of production stimulus, so that would be issues with like bone marrow, etc. Destruction issues are going to come from a red blood cell that are being broken down more rapidly than is being produced. Sometimes that happens because of a nutrient deficiency. Other times that happens because of infection or inflammatory issues that go unnoticed, especially when your doctors are running Chem 7 panels instead of Chem 21 or Chem 14. Now, the third type of anemia, so we have production, destruction. The third type of an anemia pattern is from a loss. Like red blood cells are being lost via abnormal bleeding, like in the gut. So patients that might have an ulcer, or maybe they have an issue with their colon. So cancer patients dealing with red blood cells that are being lost. These are the 3 ways that an anemia is being produced. And so I throw that out there for you, because when you look at a CBC and you're looking at red blood cell, hemoglobin, hematocrit, looking for an anemia pattern, if it's there, the question is why is it there, right? Why is it there? The type of anemia pattern you can help determine based off of MCV, MCH, and MCHC. And then third thing that we're looking for is that RDW, okay? So we get that out of the way. We have the 3 reasons for an anemia pattern: production, destruction, and loss. Okay, I'm just going to give this to you real quick here today, 20 or 30 minutes. Make sure that you have all of this information. So let's just say that we have decreased red blood cell, hemoglobin, and hematocrit, or one of those 3. One of those 3. We're going to use MCV here, and MCV is going to help us break down why we might be having an anemia pattern. So if we have a decreased MCV, what's going to happen essentially is we have a couple of options. Okay, decreased MCV, mean corpuscular volume. When we look at this, it could be an iron deficiency anemia. I'm just going to give them to you in a list form. Iron deficiency anemia, copper deficiency, vitamin A, B6 or C deficiency, zinc deficiency, and lead toxicity. Those are the options that you're going to typically find when we have a decreased MCV. When we have a normal MCV, so we have an anemia pattern with a normal red blood cell size, that doesn't necessarily mean that all of the red blood cells are normal. It means that potentially we could have a very diverse red blood cell profile. Some are the normal volume, some are of a low volume, creating a normal MCV. That can happen from a hemolytic anemia, sometimes like a magnesium deficiency, selenium deficiency, or an infection. So we're having blood loss because of that, or destruction, I should say, because of that. Inflammation, chronic disease can cause an anemia with a normal red blood cell size. Vitamin C, vitamin E deficiencies, oxidative stress. So these are your patients that work out. These are your patients that are athletes dealing with oxidative stress. These are your patients dealing with diabetes, by the way. Low RBC, hemoglobin, or hematocrit, and a normal MCV dealing with oxidative stress, which is essentially the root of diabetes if you look at it through the right lens. Protein deficiency. These are your vegetarian patients. They're anemic and they're not getting enough protein in their dietary intake. Protein deficiency. Or kidney dysfunction. This one gets me, by the way, right? This one gets me. So your patients that are on renal dialysis and just in this situation, they can have anemia patterns even though their red blood cell size is normal across the board on average. So RBC, hemoglobin, hematocrit, all right? Normal MCV. We have hemolytic anemia, so destruction anemias, inflammation, vitamin C and E deficiencies, oxidative stress, protein deficiencies, and kidney disease. Kidney disease. Now let's talk about the one that you're going to see that is, I think, most interesting. Decreased RBC, hemoglobin, hematocrit, so you know there's an anemia pattern. but you see the MCV is elevated. That can happen because of vitamin B12 or folate deficiencies, thiamine deficiencies, hypothyroidism, you'll see that commonly, and alcohol consumption. So alcohol consumption can raise the MCV value even though the red blood cells can be decreased. So it could be a lower amount of larger red blood cells with alcohol. I throw that out there because commonly you're going to have patients that are dealing with that type of a situation, and you're going to want to know, how do we tell the difference between iron deficiency and the difference between like a B12 deficiency anemia? And that's how. All right, just throwing that out there for you. So when you have, let's say, a decreased iron intake, okay, that can create an iron deficiency anemia, obviously. It could be poor absorption. That can create a deficiency, obviously. But a couple of other things here that can create an iron deficiency anemia: chronic blood loss, like if your patients are having heavy menstruation cycles, a gut bleed, we talked about that one a little bit earlier, chronic disease, chronic infection, so just a chronic immune stress. The other thing that can commonly cause low iron is progesterone birth control pills. Progesterone. That's interesting to me in that you want to make sure that you're giving your patients a thorough look through on your intake, especially if you have like a 17-year-old female, 20-year-old female, whatever it is. They come to see you and they're just tired all the time. They don't feel well. They got 5 minutes of energy every day, and you want to look at this on your intake. Are they taking birth control? What form of birth control is it? Right? You want to look for that type of a situation. So one of the ways that we can organize this is by running a CBC, right? But then you also want to run ferritin. If their iron's low but their ferritin's high, it's probably not a situation where you're going to want to give that patient iron, right? So one of the telltale signs for iron deficiency anemias is low iron, low hemoglobin, low red blood cell, low hematocrit, low ferritin, patients dealing with an iron situation, okay? So when we look at a hemolytic anemia, okay, where we have low red blood cell, low hemoglobin, low hematocrit, iron's going to be high. Iron is going to be high. So think about it think of red blood cells like a water balloon with iron. If a hemolytic anemia, so a cell destruction anemia where the red blood cells are low, the water's got to go somewhere, right? The iron's going to be elevated. That's a hemolytic anemia. That happens with chronic diseases I had mentioned previously. So when that takes place, you want to make sure that you're looking for the telltale signs. Maybe we should just create a chart for you or something like that, where you can say, all right, hemolytic anemia is going to happen in this instance. Iron's going to be high with a low red blood cell count. Right? Iron deficiency anemia, iron's going to be low with a low red blood cell count. But remember, we're using the RDW to tell you if you have a nutrient deficient anemia pattern. RDW will be high in iron deficiency anemia. Okay, so I just want to talk about that just for a couple of moments here, because this is going to make a difference to somebody's life coming up. This is going to make a difference in how your patients analyze and organize their follow-through in your clinic. It's going to make a difference. The RDW is the key. So when a doctor sees low red blood cell or low hemoglobin hematocrit and they tell the patient, you have an iron-based anemia, but they're never looking at RDW, iron, they're not looking at ferritin values. If you give a patient iron and they already have high ferritin, it's like pouring gas on a fire, right? If it's from an inflammatory issue, it's pouring gas on a fire. Those patients aren't going to feel well in the long run. That's super important to make sure that you're organizing and analyzing around that. They're not going to feel well if you pour gas on the fire, obviously. So in this instance, it's super important to use as a screening tool for your young patients that don't feel well, a CBC. For your old patients that don't feel well, a CBC. If you're not running a CBC in your patients, you're doing them a huge disservice in the long run. When we look at hemolytic anemia, so cell destruction anemia, versus an anemia of where the patient's perhaps the blood loss, all right? Let's talk about that, blood loss. One of the things that you can do to help determine the difference between the two is run reticulocytes. baby red blood cells. Run those reticulocytes, and we can figure out what's causing the anemia. Is it destruction or is it loss? Now, the iron is another way that we can determine that, right? But reticulocytes are going to be high when we have blood loss, right? Because your body's going to look at the blood volume and say, hey, we need more. They'll start pumping out more. And so in that instance, you'll see that take place relatively swiftly. It doesn't take very long for those reticulocytes to respond. So in a blood loss situation, your iron's going to be low as well, typically, in a blood loss. In a destruction, iron's high. In a loss, iron's low. All right, so I say that because I get a few emails over the last week or two just to make sure that we're talking about this. I got a few emails that are asking, how do you know the difference between iron anemia versus when to give somebody iron, when not to give somebody iron, big time. Okay, so it kind of gets a little convoluted without a chart sitting in front of you, but the point is that if the ferritin's high, you're not going to give a patient iron. If the ferritin's high, you're not going to give a patient iron. Period. So a lot of doctors will do that, and I think it's wildly inappropriate. And so good functional medicine doctor, not going to do it. All right. When we talk about your patients that are dealing with iron anemias, oftentimes they're going to have symptoms that are confusing for doctors, and probably confusing for the patient as well. But the iron anemia is something that they're going to be tired. They're going to be dizzy sometimes. Maybe they get tingly, like their face gets tingly, and so sometimes you'll see that happen. You'll see on their blood chemistry profiles patterns that are going to get flagged outside of the laboratory range, not just from a functional perspective or from an optimal range perspective. So that, to me, is interesting as well. When we look at who has an iron-based anemia situation, think with young kids, oftentimes it's going to be people that are just starting their menstruation cycles. So that happens where I never used to get, this way, but now I just feel tired. Well, look at the menstruation cycle. It might be a heavy bleeding cycle where they're not producing enough RBC content on the back end of it. That can take place. Or if we look at gut issues, right, it might be a bleed in the small intestine or in the colon. And sometimes people aren't aware of those things because they think that stool is supposed to be black and they just don't know. So questions to ask, especially when you have a little kid coming into your clinic. Okay, so all right, anemia due to chronic disease. Let's talk about this for a second. So red blood cells are created in bone marrow, remember, and as those red blood cells are created, one of the things that happens is that they respond to the level of inflammation in your body. So if you have an increased level of inflammation in a patient, let's say they have type 2 diabetes or something like that, inflammation can suppress red blood cell formation at the site of hematopoiesis, which would be in the bone marrow. When that happens, it's on a delay. You might not see it for 2 weeks. It could be a month. But what's taking place essentially is their iron is going to be normal, right? Their ferritin's going to be normal. You could test their methylmalonic acid or their B12 levels, and those are going to be normal. Vitamin C can be normal. Copper can be normal. Yet we still have a decreased level of red blood cell, and all of that to say that inflammation or chronic stress on the immune system can suppress red blood cell formation. So chronic stress, like increased reactive oxygen species, your patients that have diabetes, it's just a big time issue for them. So anyway, throwing that out there. When you have this type of a situation, if it's not a nutrient deficient anemia pattern, you're going to want to make sure that you're utilizing or supporting your patients with high levels of antioxidant therapy. So high levels, that's relative statement, okay? So that means that it has to be customized to each patient. However, you can do your patients a very good service by looking at their vitamin C. You can, as an antioxidant, by the way, vitamin C, glutathione, CoQ10, utilizing something like BioCoQ10, organizing around that, and resveratrol is another big one right now, resveratrol. But giving your patients enough of an antioxidant load that it gives them the ability to get this revved up again so that they're not dealing with an inability to deliver oxygen to the tissues that need it. So life is all about energy balance, and this is one of the ways that you can serve your patients in a way, hopefully, more effectively than the guy down the street or than the lady down the street, just because you know the difference between the types of anemia patterns. All right? So if you want more information on this, what I would suggest you do is sign up for biogenetics blood chemistry lecture on this. We go into this deep dive. We give you different ways to analyze your patient's anemia profiles, or CBCs, looking for different anemias in that profile. And pathways, things that you can do, ideas, clinical interpretation, and clinical follow-through. The clinical pearls are where it's at when it comes to helping your patients heal. So anyway, just a quick episode here of the Nutrition Hero podcast, just to give you an update on, number one, planking. Just kidding. Give you an update on the CBC panel and how you can utilize it to better serve your patients, especially the ones that are dealing with chronic low energy. All right. I'm Dr. Brad Watts. You're listening to the Nutrition Hero podcast. Thanks for tuning in today. Coming back with some interviews coming up here. A gentleman named Dr. Brandon Brock, who I think you'll appreciate, and a doctor named Dr. Randy Johns, who I think has an amazing story and inspiring story, and we'll go from there. All right. Have a great day, everybody.